Hello everyone. This is the lecture which I had taken in one of the conferences latest, and it has been appreciated by many of them. So I thought I should be sharing my knowledge which I recollected during preparing this lecture. So the lecture was on impact of thyroid gland on the reproductive endocrinology. So this is very important to know how does thyroid gland impact, because we all know the treatment for the disease is, if it is a hypothyroidism, then you have to give altroxin. If it is a hypothyroidism, you have to give methimazole or carbimazole. But when to treat, that is the very important thing, and why to treat, that is another important, so as to convince that in many of the situations we need to treat the subclinical hypothyroidism also. This is my small CV. So the learning objective of the current presentation is the impact of thyroid hormone on reproductive endocrinology, thyroid autoimmunity, and I have just added for this lecture gray zone of subclinical hypothyroidism, what the evidences say. I'm not going to cover the pregnancy part because that was taken by some other person in that conference, right? So I will be concentrating on these three topics. Okay. So this is one of the article published in one of the papers, that 1/3 of the Indians suffer from thyroid disorders. So this much is the prevalence of the disease in the India. And this is the article published in Lancet in 2014, way back. It's around 6-7 years back, that there are around 42 million people who are suffering from some or the other kind of thyroid disorder, and the prevalence of hypothyroidism in India is around 11%, and this is despite the supplementation of the iodized salt. So if you see whole human body, the thyroid hormone regulates the metabolism in practically all tissues in the human body, and adequate thyroid hormone availability is required for the normal human reproduction. And in my lecture, I am going to concentrate only on the reproductive tract, what happens, how does it affect, right? So if you see in day-to-day practice, what all things we encounter if the patient is suffering from a thyroid disorder. It can be pregnancy related, that I have made with orange, so that I'm not going to cover this. So menstrual disturbances, it is common in hypo as well as hyperthyroidism, and it has been seen that 25 to 60% of the females suffering from a hypothyroidism have some or the other kind of menstrual disorder. They can suffer from anovulation, and this can cause a reduced fertility and recurrent pregnancy loss. Now here the question arises, why this occurs? What happens? How does this thyroid hormone is going to impact the reproductive tract? So if we recollect our past knowledge, that hypothalamus is secreting the TRH. TRH stimulates the anterior pituitary, and this anterior pituitary secretes TSH so as to stimulate the thyroid gland to secrete a T3 and T4. And T3 is the most active form, but T4 is in abundant, which is converted into T3 in the peripheral tissue. And now this is going to give a negative feedback that we are in adequate amount. So now you less secrete TSH and TRH. So this is a general cycle which happens. But how does it affect the reproductive tract? So, thyroid hormone within the normal range regulates the stimulatory effect of FSH on the follicular growth. There are abundant receptor present on the preantral follicles. It stimulates the granulosa cell. It stimulates the LHN-HCG receptors to produce the adequate amount of the progesterones, and it also causes a apoptosis suppression. And remember this point, because I am going to talk it later on, why it is very important to have a apoptotic suppression under the effect of the thyroid hormone during the follicular growth. So what happens in the hypothyroidism? Right? So let's see So what happens if the hypothyroidism is there? So if the thyroid hormone is low, what will happen? There will be an increased TRH. That means thyrotropin releasing hormone, and this causes increase in the TSH and prolactin. Why there occurs an increase in the prolactin? Because the lactotropic cells have a receptor which simulates or which has a receptor similar to the TSH. So this TSH is going to act on these lactotropic cell, and there is an increased secretion of prolactin, and this hyperprolactinemia is seen in cases of around 22 to 57% of the cases. And this hyperprolactinemia along with the increased TSH affects the pulsatile release of GnRH, and you know that the pulsatile release of GnRH is very important to have an adequate secretion of the FSH and the LH and to stimulate the ovary. So when it affects, it decreases the pulsatile release of GnRH. Therefore, what happens? There occurs a decrease in the FSH and LH cyclical release, and this causes infrequent cycles, HMB, and anovulation, which lead to infertility and subfertility. And this is not the only action which is happening simultaneously, because the thyroid hormone is affecting the whole body metabolism. What it is doing? It is decreasing the metabolism all over the body, which causes decrease in the serum hormone binding globulin, and this serum hormone binding globulin decrease will cause a effective increase in the free estradiol level, and this free estradiol level is going to act on the endometrium and causing unopposed estrogenic action, leading to endometrial thickness and heavy menstrual bleeding. Besides that, this pulsatile release of GnRH when is there in the children, right? So if hypothyroidism is affecting the children, what is happening? There is a decreased pulsatile release of GnRH, which cause the delayed sexual maturity. But in some cases, there can occur a precocious puberty also. As in this case, you see this von Wieck-Grumbeck syndrome is a rare cause of ovarian cyst and precocious puberty in children. And what happens in this condition? There occurs a profound hypothyroidism, and this profound hypothyroidism is due to autoimmunity, and this decreased hormone level causes an increase in the TSH level, and this TSH level simulates the FSH, and this FSH is now going to stimulate lot of follicles, which causes a multicystic ovary and a increase in the estradiol levels, and this causes a uterine bleeding, breast enlargement in the young females who have yet not reached puberty, but they appear as a pseudo-precocious puberty. Simultaneously, there is a decreased bone growth and neural development, right? So now coming specifically to ovary, how does it impacts the ovarian follicle, right? So ovarian function regulation is via nitric oxide synthase activity. So whenever there is a hypothyroidism, there is a decrease in the granulosa cell aromatase activity. And if you remember the two-cell theory, what happens? This progesterone goes in the granulosa cell, and there, due to the presence of aromatase, it is converted into estrogen. But now, because of the decreased thyroid hormone, there is a decreased granulosa cell aromatase activity, which leads to decreased estrogen production, and because of this, ovulation is affected, right? Besides that, as I have told you, that there is an abundance of TSH receptors or thyroid hormone receptors over the preantral follicles also. So there occurs a impaired preantral follicular development. Due to this, there is an effect on the follicular maturation, because of which the ovulation is affected, and this lead to infertility and subfertility. Besides this is not the only action. Thyroid hormone, as I told you, it also affects the LH and the HCG receptor. So LH receptors and the progesterone production is also affected when there is a hypothyroidism, and this lead to implantation problems and the miscarriages. I hope this whole mechanism, the whole pathophysiology is very much clear to all, to you all now. Now, let me talk of something like auto. What I mean by this? I mean by this that I'm going to talk about antibody, and thyroid autoantibodies and subfertility has got a relationship with the female reproduction. Let's see how does it affect. So thyroid and autoantibodies and subfertility. So autoimmune thyroid disease is the most common cause of hypothyroidism in reproductive age group. Prevalence is more in subfertile population and more commonly associated with endometriosis and PCOS. You see, in the last 1 decade, there is an increase in the autoimmune diseases like thyroid disease, PCOS and metabolic syndrome. And thyroid autoimmunity is thought to be present in around 10 to 25% of the general population. And many a times these females have a normal TSH levels. Remember this point, right? And it has been seen that if you see the thyroid disorders like in Hashimoto thyroiditis, 100% of the females are going to have a thyroid antibodies. Postpartum thyroiditis, 2/3 of the females are going to have a thyroid autoantibodies. And if we talk about Graves' disease, around 3/4 of the females are, that means 75% of the cases are going to have a autoantibodies, which is going to affect the fertility. So what two antibodies we generally test? We test for TPO antibodies very frequently. And now there are guidelines that we should be from the European Society that we should be testing for the thyroglobulin antibodies also, and that is equally important. So these are the guidelines only from the European Society, not for any else society. So currently we are testing for TPO antibodies. So now how does these TPO antibodies are affecting the body? So the studies have shown that if you see the serum levels, that simulates the antibodies in the ovarian follicular fluid. That means it is affecting the ovary. So what does these antibodies do? They stimulates the polyclonal B cells cross-reacting with the trophoblast placental tissue, increased T cell in endometrium, problems the implantation, and NK cell hyperactivity which migrates into uterus and cross-react with the placental and zona pellucida antibody. So coming to the subclinical hypothyroidism, which I talked in the initial lecture also, that is a gray area, when to treat, when not to treat, and why they need a treatment. When the physician is not treating, why we as a gynecologist or an obstetrician want to treat this disease. So what we are bothered of? We are bothered of subfertility, the women who are undergoing ART, and when we are talking of pregnancy and recurrent pregnancy loss. These are the situations where we need to treat the subclinical hypothyroidism. But why we need to treat? So if the woman is going under ART or subfertility, what is happening? You are stimulating the ovary. You are doing a controlled ovarian hyperstimulation. And this ovarian hyperstimulation is going to increase the estradiol level. You see, one follicle is contributing to around 250 picogram. Right, so this increased estradiol level, and you are getting around 12 to 12 follicles, that amounts to 2500 picogram. That is too much, and that affects the body metabolism. So how does this affect? So it increases the SHBG level, and this SHBG, it causes an increase in the thyroid bonding globulin, and this thyroid bonding globulin is going to bind the thyroid hormone, and this decreases the free thyroid hormone, right? So if the patient is subclinical hypothyroidism, it appears as a there occurs a more of a hypothyroidism. But if your body is okay, it is going to sustain. But if the body is already having a deficiency of a thyroid hormone, or you are having a thyroid autoimmunity, then your thyroid hormone is going to be affected a lot, and this decreased thyroid hormone will cause decreased granulosa cell aromatase activity and impaired pre-antral follicular development, and also it will affect the implantation process. That's why it is said that you must be controlling the hypothyroidism, subclinical hypothyroidism, before taking up the patient for ART. Right, so that's why there is a decreased conception rate in a hypothyroid patient who are undergoing a ART or who are having a subfertility. So now coming to the what happens in the recurrent pregnancy loss with hypothyroidism. So whenever there is a pregnancy, there occurs an increase in the estrogen secretion, and this estrogen secretion, as I already told you, is going to increase the hormone binding globulins. So there is an increase in the thyroid binding globulins, and this thyroid binding globulin increase will cause a relative deficiency of the thyroid hormone, right? So moreover, there occurs an increased GFR in the pregnancy, and this increased GFR is going to increase the clearance of the hormone. Again, there will occur a thyroid deficiency. If there is moreover, there is a relative iodine deficiency due to the increased clearance and the placental transfer of iodine. So there occurs a decreased formation of thyroid hormone, and this lead to recurrent pregnancy loss, right? Coming to the hyperthyroidism, what happens in the hyperthyroidism? You see, in hyperthyroidism, there is an increase in the LH hormone, there is an increase in the SHBG, there is an increase in the androgen and the estrogen production and conversion, and these lead to menstrual disorder and infertility. Right, the extent to which hypothyroidism is related to fertility issue is not well understood, but in general, if not treated adequately, hypothyroidism is associated with recurrent pregnancy loss. So these are the guidelines which are available with us regarding the thyroid hormone treatment. ASRM guidelines have been given in 2015. American Thyroid Association guidelines have been given in 2017. RCOG guidelines have come in 2015, and the European guidelines have come in 2021. So these are the latest one. So what should be the reference range of TSH and T3, T4? It has been said that the normal TSH reference range changes with the age and it increases with the age. And every lab in particular community or a setup should set their own reference range. But if those are not available, what can be done? So if an age-based upper limit for the normal for a third generation TSH assay is not available in an iodine sufficient area, an upper limit of 4.12 should be considered as per ASRM guidelines 2015. And they say that the reference range of TSH in pregnancy is to be dependent on trimester wise, and for first trimester it is 2.5, second trimester it is 3, and third trimester it is 3.5 as per ASRM guidelines. Whereas American Thyroid Association guideline 2017 say that you reduce the lower limit of the reference range by approximately 0.5 and the upper limit by 0.5. So finally the range comes to be 0.1 to 4 milli-international unit during pregnancy. So as per American guideline, the upper limit is 4, but as per ASRM it is 2.5 to 3.5 depending upon the trimester. So hyperthyroid, if it is less than 0.5 with raised T3, T4, we say it frank hypothyroidism. But if the thyroid hormone TSH is below normal but T3, T4 are in normal range, then this is called as subclinical hyperthyroidism. hypothyroidism, and there is no need to treat asymptomatic non-pregnant adult for a TSH level 5 to 10 milli-international unit. If there are no symptoms, there is no need to treat the patient, and they are called as subclinical hypothyroidism. But if they are suffering from some or the other disease, is like fertility, decreased fertility, menstrual disorder, then you need to treat the patient. Coming to the gray zone, subclinical hypothyroidism. This is very important. Why it is important? We all know that if the TSH level is more than 4, and if the patient is suffering from either subfertility, recurrent pregnancy loss, or going for IRT, we need to treat the patient. But this is the gray zone area between 2.5 to 4 with a normal T3, T4. What is to be done in these conditions? And there are specific guidelines when you should be treating, but to summarize, you need to treat the patient if during this time period if she is anti-TPO antibody positive. But let's see what the evidences say. So, is untreated clinical hypothyroidism associated with infertility need treatment? There are insufficient data to conclude that subclinical hypothyroidism is clearly associated with infertility, but in the workup of the infertile women, it is recommended to test all women with TSH, and if TSH concentrations are over the lab reference range, that is typically more than 4, patients should be treated with levothyroxine. And the aim of the treatment should be to decrease it to less than 2.5. If the TSH level prior to pregnancy are between 2.5 to 4, management options include either you keep the patient for monitoring or treat the patient when TSH is more than 4, or treat with levothyroxine if it is coming persistently in this range. In women with TSH level more than 2.5 and thyroid autoimmunity, it is recommended to initiate the treatment on case-to-case basis, taking into account and a history of previously failed ART treatment. Are thyroid antibodies are associated with infertility or adverse reproductive outcome? So what does they say? That TAI is associated with miscarriage, and there is a fair evidence that it is associated with infertility, and LT4 treatment may improve the pregnancy outcome in women with the positive antibodies, especially if TSH level is over 2.4, and this is a good level of evidence. So we must be starting a treatment above 2.4 if TAI is positive. While TAI testing is not routinely recommended, one might consider anti-TPO antibody testing if it is more than 2.5 or any other risk factor for the thyroid disease are present. If anti-TPO bodies are detected, TSH level should be checked and treatment should be considered if the TSH is over 2.5. Does treatment of subclinical hypothyroidism improve the miscarriage rates, live birth rates, or clinical pregnancy rate? Yes, there is a good evidence that LT4 treatment in women with subclinical hypothyroidism treatment as TSH more than 4 is associated with improvement in miscarriages and pregnancy. There is insufficient evidence that thyroxine therapy in women with TSH between 2.5 to 4 is associated with improved pregnancy outcome. Is untreated subclinical hypothyroidism associated with miscarriages? There is evidence that anytime if TSH level is more than 4, it is associated with miscarriages, but insufficient evidence is there that the TSH level between 2.5 and 4 is associated with miscarriage. So anyways, you need to treat the patient if the TSH level is more than 4, and if autoimmunity is present, consider treatment between 2.5 to 4 also. So these are the European guidelines. I have already told that they have added that subfertility patients should be tested for TSH and TPO antibody, and TG antibody can be added systematically. Subfertile women with TSH levels more than 2.5 and without increased TPO antibody levels should be screened for thyroglobulin antibody. This I have told initially. And levothyroxine treatment should be started promptly in case of overthyroid and should be started whenever it is more than 4 in subclinical hypothyroidism, and should be started if the TPO antibody positive between 2.5 to 4. So this is a beautiful study where they have found that the lower T3 and TPO antibody positivity rates are associated with low antral follicular count in a woman with diminished ovarian reserve or unexplained infertility. So, thyroid disorders and the ovarian retrieval rate, fertilization and embryo quality, yes, there is evidence. So, they say that offer ICSI for women with the evidence of thyroid autoimmunity as the preferred fertilization method in the course of assisted reproduction. And levothyroxine treatment in women with TAI and TSH level more than 4 should have an aim to keep the levels below 2.5. Levothyroxine treatment in subfertile women with TAI and TSH level more than 2.4 on a case-to-case basis to allow for an optimized fertility outcome. Thyroid function and the ovarian stimulation. So this recommend that check TSH level after ovarian stimulation, as I told you why it is to be tested and why it is to be supplemented if there is a hypothyroidism. So in women with TAI during LT4 treatment or after initiation of it. So you must be checking the TSH level with a patient on treatment, and then you have to increase or decrease the dose accordingly. But there is no recommendation for TSH monitoring after ovarian stimulation for a euthyroid woman. You need to adjust the dose. I had already told. Treat TAI positive women with TSH level between 2.5 to 4. Treating TAI positive women with TSH level more than 4 before ovarian stimulation to keep the serum TSH level less than 2.5. Treat TAI negative women with TSH level more than 4, and no recommendation is there for treating euthyroid women without TAI before ovarian stimulation. So these are the two trials which you need to see to have when does the thyroid treatment should be given, what does the evidence says. These are the recently published trials, tablet trial and the postal study. So to conclude, thyroid hormone has an impact on all aspects of fertility. Menstrual disorder, infertility and recurrent pregnancy loss are the common occurrence. Routine measurement of TSH should be done in all cases along with pregnancy, and pregnancy specific ranges should be used. Women with subfertility for ART, RPL should be subjected to TPO antibody level only if the TSH level are more than 2.5, and all the women with above disorder should be treated at level above more than 4. And women with TI should be treated if the level of TSH is between 2.5 to 4, but the treatment can vary on case-to-case basis. So that was all about, and these are my lectures. You can go to my website and subscribe to my latest lecture with all the updates on my website. Keep writing on to me or this email so as what you want from me, anything new you want me to add. Thank you.